Welcome. Thank you so much for joining us. I'm Celina Yong. I'm an associate editor at JACC, and we are thrilled today to get to talk about the DCB-BIF trial, which is the first major RCT of drug-coated balloons in bifurcation lesions. We are excited to publish this in JACC simultaneous with its presentation at TCT as a late-breaking clinical trial. And we have the privilege today of speaking with senior author, Dr. Shao-Liang Chen, who is from the Nanjing First Hospital in China, as well as our esteemed panelist, Dr. Ziad A Ali from the St. Francis Hospital and Heart Center and New York Institute of Technology, and Dr. Jacqueline Tamis-Holland from the Cleveland Clinic. So, Dr. Chen, do you think you could start us off with just a high-level overview of the study and what your findings were?
Okay, thank you, Celina. Thank you, Jad, my close friend. Thank you, Jacqueline. So the trial is drug-coated balloon angioplasty for side branch during provisional stenting. It's a multi-center randomized prospective DCB-BIF trial. I'm Dr. Shao-Liang Chen from Nanjing First Hospital. So in general, there are several major inclusion criteria, particularly, according to our definition criteria, we only include a patient with simple coronary bifurcation lesion, defined by the sub-branch lesion length shorter than 10 millimeters, and a ostial sub-branch diameter stenosis is minimum 70% of the stenting in the main vessel. This is study flow chart. From the figure, you can see finally 784 patients with sub-branch ostial diameter stenosis minimum 70% after stenting main vessel were randomized to drug-coated balloon DCB group and another 393 patients in the non-compliant balloon group. Finally, so all patients included in the ITT analysis. So these are a baseline lesion and procedural characteristics. Most of bifurcation lesion classified by Medina 111 and 011 in two groups. So multivessel disease were monitored in greater than 75% among overall patient population. So almost 15% of lesion localized as a distal left main. Most procedures were done by transradial approach. So basically, from the table, you can see the predilation for side branch before stenting main vessel was required for almost 20% in either group. Finally, after the side branch ballooning, kissing balloon inflation was performed in greater than 95% of the patient, particularly after the whole procedure, the crossover rate from provisional to two-stent approach was pretty low, only around 3.5% for both groups. Intravascular image guidance was used in less than 26% of patients. The primary endpoint was a one-year target lesion failure, TLF, including cardiac death, target vessel myocardial infarction, and clinical-driven target lesion revascularization. By 1 year follow-up, the primary endpoint occurred in 7.2% in the DCB group compared to 12.5% in the NCB group with very significant p-value. So in terms of the individual components of primary endpoint, so you can see the significant difference in TF was mainly driven by target vessel myocardial infarction. So it was 5.6% in the DCB group compared to 10.9% in the NCB group, mostly driven by high rate of spontaneous myocardial infarction in the NCB group compared to DCB group. Unfortunately, there was no significant difference in terms of the clinical-driven TR, which was 1.3% in the DCB group and 1.5% in the NCB group. There was no difference in stent thrombosis between two groups. This is the final KM Kaplan-Meier curve to show the significant difference in terms of the primary endpoint target lesion failure. So this is the brief introduction of my trial. Thank you. Thank you so much.
Thank you so much for sharing that with us, and congratulations on completing this trial. I wonder if for our first few questions here, I could turn to Dr. Ali. When we looked at these trial findings, we found it quite interesting that the target vessel MI was lower in the DCB arm. However, the target lesion revascularization was not. And we might have expected those to kind of track together. What are your thoughts about this and the reasons why this might be the case?
Thanks, Celina. And Shao-Liang, congratulations to you for conducting a study that I don't think could have been conducted anywhere else. I mean, if you think about randomizing 800 patients who get a PCI and then have a pinch side branch and are then randomized to drug-coated balloon, non-compliant balloon with excellent procedural markers, it's a true testament to the type of work that's done at Nanjing. So congratulations. So of course, it is a very interesting finding that you have a target vessel myocardial infarction that is orders of magnitude higher than target lesion revascularization. So why could something like that happen? And the things that come to mind are, you don't know where the myocardial infarction came from, meaning it's indeterminate, and that could be indeterminate because you performed angiography and couldn't determine where it came from. No thrombus, no ulcers, no flaps. Or you never tried to determine it because you never had an angiography because it was simply an enzyme leak as opposed to spontaneous, for example, myocardial infarction. The second would be if you do an angiogram and you see that there's no significant lesion. You don't find a culprit lesion. And the stenosis, for example, in the side branch isn't severe enough. And finally, of course, the whole reason we're doing this study is because side branch interventions are complex. And if the PCI becomes more complex to save a side branch than the actual index PCI itself, operators have a degree of hesitancy. And so these are some of the reasons why we might see a difference between target lesion revascularization and target vessel myocardial infarction. But we should also pay attention to some of the very important things that we do as interventionalists with drug-coated balloons that are different to non-compliant balloons. And really, right at the top of that list is how long we inflate the balloon for. Now, one of the things that becomes popular and is actually recommended from the manufacturer is to leave the balloon up in a drug-coated balloon to actually deliver antiproliferative into the wall for a longer period of time. Minimum recommendation, 60 seconds. In our institution, it's 3 minutes. And there are a number of studies which actually show that by doing that, you can reduce dissection or tack them up, perhaps even precondition the artery for later on. And so that might be one of the main reasons. And so as you remember, Celina, when we were going through this paper, one of the striking findings was that most of the events happen very, very early on, within several days of the procedure. And that's what makes ultimately the application of this data difficult into clinical practice.
Thank you. You know, the other issue that we had discussed was the spontaneous and the periprocedural MI. And it was interesting that spontaneous MI was significantly worse in the NCB arm, but there was no difference in periprocedural. However, numerically, there were actually more periprocedural MIs. What do you make of that finding?
You know, if you look at the Kaplan-Meier curves carefully, I believe that the periprocedural and spontaneous myocardial infarctions are rather a continuum because they all happen relatively early. So this may be a sky definition. We cut, the pie at this point, and one side is spontaneous and one side is periprocedural. And then, of course, we expect that the unplanned spontaneous MIs have unplanned revascularization or have angiography. And so I believe the predominant reason for this is a continuum of enzyme elevation that may not have otherwise been assessed very early after the procedure.
Those are great points. Dr. Tamis-Holland, at face value, this is a positive study for DCBs. Do you think DCBs should become standard of care for bifurcations, or how are you thinking of this in terms of your clinical practice?
Thank you, Celina. Personally, I don't see from our trial, DCB could be the standard care for bifurcation lesion. I think there are several reasons. The first is, in this trial, we only include patients with simple coronary bifurcation lesion. Simple means, actually, so far there is only one definition criteria to differentiate simple from complex bifurcation lesion. So for such a simple lesion, the provisional stenting is the main standing technique. So the key point is that once there is a severe compromised side branch, how do we do? So usually we need to use an NC balloon. So this trial compared the treatment difference between two different kinds of balloon. Second point is that even there is a high rate of spontaneous myocardial infarction. To be honest, from daily practice, usually we do not do routine angiography for patient with a spontaneous myocardial infarction, but clinically very stable. So I think this is why there is low rate of tight lesion revascularization. Third point is that tight lesion revascularization was defined driven by clinical symptoms in this trial. That's back to the previous published several trials. For example, from the EBC-man trial, which only included distal left bifurcation lesion. So the TLR rate in the provisional stenting group was 6.1%. It was 6.3% from Cactus trial, and 7% in DKQH2, and 8% in the DKQH5. Even there is a difference in the inclusion of different bifurcation lesion localization. But it's very clear to say the 1 year TLR rate of the provisional stenting technique varies from 6% to 8%. But for our DCB-BIF trial, because we only included simple bifurcation lesion, so the TLR is pretty low, only 1.3 in the DCB group and 1.5 in the non-NCB group. So I think TLR is only one component of the primary endpoint. Because of the small sample size, we could not achieve the significant difference. Finally, I'd like to say we are planning to design one more clinical trial to compare DCB with NCB during provisional stenting technique for real complex bifurcation lesion. If it's the case, I think it will be possible to get positive result. Thank you.
That's exciting. We anxiously await that next trial. I would love to turn to Dr. Tamis-Holland to get your take on how you integrate this into your clinical practice.
Sure. First of all, congratulations, Dr. Chen. I was actually just thinking of this the other day because we recently received the drug-coated balloons. I guess about 6 months ago, we've been using it for here in the United States. And we had encountered that exact situation. We said, well, should we be side branching this, doing the side branch with a drug-coated balloon? And the thought came up, so I'm delighted to hear you answer that question for us. I will tell you that I think it was a fantastic study. I was a little disappointed to see there was no difference in TLR, because when I think of doing a side branch, we often talk about the fact that you can leave a 70% lesion alone and they do just fine, because for the most part, it's the main branch that's really causing their angina. But we all instinctively want to treat that 70%. So the success rate of how well you can treat it will not be dictated by the drug-coated balloon up front, like in the lab. You're either going to get a dissection or get it to respond to the balloon inflation or not. And the addition of the drug coating is not going to change your upfront success. But long-term, we wonder whether it's going to be a lower rate of TLR, and that's what's going to benefit the patient. So if we can get a 50% or a 30% residual side branch, we're happy, and we hope that this won't result in TLR over time. So I was disappointed to see there was no difference in the TLR, because in my mind, that would be the mechanism by which this would work. And that we would see a difference in target lesion failure is mainly due to TLR, not so much due to spontaneous MI. I recognize, like you said, that the power, would have to be so much higher in this study to be able to show that. But I would have liked to have seen a better TLR rate. In terms of adoption in the United States, I think it's a little, it's hard to say, because I think, as we all know, we're really limited by FDA indication and cost. And even though we oftentimes go off label for a lot of things that are FDA indicated or not indicated for a certain reason, when the cost of the balloon is so pricey, it makes it a little harder to go off label for these types of situations. I hope, and also not every hospital in the United States has drug-coated balloons just yet. So I hope that with the uptake of drug-coated balloons across the United States, potentially more coming on the market, so the costs won't be so high, that we will be able to use this, and based on Dr. Chen's results, be able to use it in the situations where we are worried about restenosis or just target vessel failure, and hope that this will make a difference.
You know, Celina, I'd like to add a couple of things to Jacqueline, and that is, it's really important finding that the TLR rate in 800 patients who had 70% pinch side branch is 1.5%. I mean, so what that's telling us is that biologically, these pinches and carina shifts don't lead to TLR, whether or not you've got a drug-coated balloon afterwards. And so the important, very important steps, which Professor Chen highlighted in the study, performing a side branch dilatation, performing kissing balloon inflation, doing a post-pot, all of those steps, which are good practice in interventional cardiology, likely limit TLR. The second point, which is also very important, is we have to remember the mechanism of failure for simple side branch pinch. And this is because the ostium of the side branch is the most muscular part of the artery. So a lot of what's happening is not neointimal hyperplasia. It's simply recoil. That recoil is mitigated by the presence of a mechanical scaffold, i.e. a stent. But outside of the stent, the failure we expect where the drug really works, which is neointimal hyperplasia, probably is only a very small part of the biological response. And that's why I think what Shao-Liang is doing for more complex lesions makes a lot more sense, because neointimal hyperplasia and vascular injury in more complex lesions is much more likely to be impacted by drug-coated balloon than simply an ostial pinch.
Yeah, thank you for your comments. One more point that I'd like to share with you. I did not include in my slides for brief introduction, but we do provide the dynamic change of QFR at baseline after the procedure, during procedure, and after stenting side branch in general paper. I think you can see the result from the JACC. So actually, you know, whatever the post-dilation, the pre-dilation using NCB or DCB, so the side branch QFR was improved much more. I think the key question, another key question is that we need to expand our clinical follow-up to 2 years, 3 years, or even 5 years to see what will happen during long-term clinical follow-up. Thank you.
That would be great. I think it'll be really interesting to see if there's a difference. And I do agree, Dr. Ziad, that the longer lesions with more sort of just plain old, you're worried about neointimal atherosclerosis are, that's the one that maybe the drug-coated balloons will be of help. I just have one question for you, because again, as a new adapter in the United States, we're all new to this. Well, one comment and one question. I noticed that you did use kissing balloon post-dilatation, and to be quite honest, we're new to this, but we've been told to really avoid manipulating the artery with any further intervention, particularly a balloon, because that might wash away the coating or whatnot. So, what are your thoughts, since you have so much experience with this? In the United States, we don't, but we're told not to reintroduce another balloon. And I saw that 94% of the time you had kissing balloon inflation in the side branch afterwards.
Yeah, thank you. I think it's a very challenging question for me. But beyond your question, I think there are two more additional points I'd like to share with you. The first is that, to comply with the philosophy of provisional stenting technique for coronary bifurcation, usually we do not recommend to pre-dilate side branch before stenting main vessel. So this is the key point, first key point. Second one is that, after stenting main vessel, after ballooning side branch, usually usually do not need to do kissing balloon inflation. But for cases with very severely compromised side branch, we have to do. But this next point is that even, yeah, whether a kissing balloon inflation is good or not good, there is no conclusive evidence even from EBC consortium. But from our trial, once we do kissing balloon inflation, we have to do PAR technique. So far, even for PAR technique, still there is some arguments. So far, actually there is no clinical evidence to support the routine use of PART. But we are using PART during our everyday practice. But another key problem is about the PART, because so far we have no very short balloon to do PART technique. So even from our DCB-BIF trial, we also found several cases of the PART technique. So there is a very severe proximal edge dissection. So I think every step could have some severe complication. Is that your question?
Actually, that's an interesting point, but that wasn't my question. My question was not the safety, but the efficacy of a drug-coated balloon result after you've ballooned it again. We're told to not balloon it or not intervene on it again, obviously unless there's a dissection or whatnot, when you're done with the drug-coated balloon, because it might wash away the coating. And
yeah, actually, oh, I'm sorry. I think it's an academic question. Actually, before DCB-BIF trial, there are 3 papers published about the use of NCB balloon to do kissing balloon inflation after ballooning side branch using DCB. It means after stenting vessel, DCB for side branch, kissing using another NCB in side branch. So all these study results support the routine use of NCB to do kissing. This is the first point. Next, I think Celina probably remember, we have provided one more figure in our appendix to show how many drugs lost by main vessel stents drugs. I think this is another academic question. Thank you.
Well, thank you so much, Professor Chen and Dr. Tamis-Holland and Dr. A Ali. I think as Dr. Ali, we wrote in our editorial, to kiss or be kissed. I think it's not a simple answer. And I really appreciate all of your time and thoughts about this really important trial. Congratulations again, Professor Chen. And we're thrilled to publish this in JACC and excited to see your upcoming presentation. Thank you all.
Thank you. See you all in TCT. Bye-bye.
Bye-bye. See you at TCT.